Welcome to the webinar on desensitization in the highly sensitized pediatric transplant patients, novel strategies for both heart and lung transplantation, organized by the ISHLT pediatrics professional community. I'm Brigitte Willemse, pediatric pulmonologist at the University Medical Center in Groningen, the Netherlands, and I'm happy to introduce to you my co-chair, Dr. Kathleen Simpson. She's an associate professor of pediatrics and pediatric cardiologist at Colorado Children's Hospital in Denver, and currently the chair of this community. Today's faculty is represented by Dr. Amanda Long McCormick, Dr. Lakshmi Loganapudiham, and Dr. Sarah Nicholas. First, all lectures will be presented, and afterwards we will have a panel discussion. During the lectures, you can enter your questions in the chat, and they will be discussed during the panel discussion or answered via the chat. We hope you enjoyed this webinar, and we look forward to a lot of questions in the chat. And I'm happy to introduce you to the first speaker, Dr. Amanda DeLong McCormick, who is an assistant professor at pediatrics at C.S. Moss Children's Hospital in Michigan. And she will start with a case presentation on a highly sensitized patient to get familiar with all the difficulties one can encounter with these patients.
Thank you so much for the opportunity to present today. I'm going to start out with the case. This is a 9-year-old male with a history of dilated cardiomyopathy who received a heart transplant 7 years ago, who presents with new onset heart failure symptoms in the setting of recent medication non-adherence, a story I'm sure we've all heard many times. He undergoes cardiac catheterization that shows new elevation in his RV-EDP, as well as his PCW, and has an endomyocardial biopsy, which is negative for acute cellular rejection, but new noted p-AMR1I+. This is his initial donor-specific antibodies. He had a previously negative DSA, now with both class 1 and class 2 antibodies that are elevated. This is a neat sample. The titers are there for you in red for the DR4 and DQ8. He underwent treatment for AMR with the protocol at our center at the time, which included pulse dose steroids, plasmapheresis with IVIG, and 1 dose of rituximab. About 24 to 48 hours after his dose of rituximab, he suffered a bowel perforation and underwent right hemicolectomy and end ileostomy. Over the next weeks to months, he had a progressive clinical decline with diastolic heart failure with milrinone dependence, acute kidney injury and volume overload requiring intermittent HD, refractory ascites requiring intermittent paracenteses, and ultimately was evaluated for a combined heart-kidney transplant. This is his PRA post-Plex IVIG and the 1 dose of Ritux. The repeat DSA is there for you on the far left with persistent high levels of DQ8. His full PRA assessment is in the center. And then as a summary, he had no class 1 antibodies, but several high MFI greater than 7,000 class 2 DQ antibodies, including that DQ8 that I mentioned. We then were faced with how to proceed forward for possible heart-kidney transplant. Due to the temporal correlation between rituximab and his bowel perforation, we felt that proceeding with additional rituximab therapy was not appropriate. We just felt that bortezomib was not felt to be ideal due to his primary class 2 HLA antibodies, and then ultimately began weekly treatment with daratumumab and IVIG, and was listed status 1A by exception for combined heart-kidney. This graph shows the MFI of HLA antibodies pre and post daratumumab. Pre-daratumumab is in the left column, post-daratumumab on the right. Class 1 is in the top row and class 2 in the bottom row. You can see that from pre-daratumumab to post-daratumumab, he had a significant decrease in his class 1 antibodies, as well as some decrease in his class 2s, but a persistent calculated PRA at 56% per our center. Overall, his CPRA decreased from 99% to 55% with reduction in both class 1 and class 2 antibodies after 8 weeks of daratumumab therapy. This is looking at his DQ3, 7, 8, and 9 a little bit more closely, which was semi-refractory to treatment. You can see there where his DQ8 trended as far as his neat MFI, both pre and post daratumumab and IVIG infusions. Ultimately, his daratumumab treatments, which we dosed at 8 mg per kg, were spaced biweekly during the waitlist period, during which time he received a total of 4 doses. He underwent a successful heart-kidney transplant about 15 months after his initial rejection episode and received only 1 dose of daratumumab post-transplant. In full transparency, it was our intention to continue daratumumab post-transplant to keep any rebound DSA at bay. Unfortunately, due to insurance woes, we were unable to continue therapy and so monitored him very closely. No further doses of daratumumab or IVIG have been administered at this point, and he has not developed DSA or rebound PRA and is now 24 months post-transplant. Thank you so much again for the opportunity to present, and I'd be happy to answer any additional questions in the chat.
Thank you, Amanda, for this great presentation on this nice and interesting case. I think we are looking forward to your questions in the chat, and I would like to introduce to you the second speaker, which is Dr. Lakshmi Goganaputty-Han, and she's an assistant professor of pediatrics at Washington University in St. Louis and part of the advanced heart failure and heart transplant team at St. Louis Children's Hospital. She's going to tell you all about how to approach the highly sensitized pediatric heart transplant candidate.
Thank you. I'm going to talk about the sensitized pediatric heart transplant candidate. So the prevalence of sensitization, which we can define in many ways, but if we look at PRA greater than 10%, it's been reported to be anywhere from 11% to 21% and is noted to be increasing over time. And it's increasing because of the rising occurrence of retransplantation and use of mechanical circulatory support as a bridge to transplant. There's also an increasing number of children with congenital heart disease who are sensitized by prior cardiac surgery and implantation of cryopreserved homografts. So sensitization has been associated with increased waiting times to transplant, reduced patient survival, increased cell-mediated as well as antibody-mediated rejection, and coronary vasculopathy. An analysis of all children listed for pediatric heart transplant from 1995 to 2009 in the US found that requiring a negative prospective cross-match increased waiting time and, more importantly, increased waitlist mortality. And so specifically looking at patients with high PRA, the CTOT-C4 study observed that transplant across a positive cross-match in sensitized patients, which they defined as MFI greater than 1,000, was associated with acceptable first-year graft and patient survival, but they did notice AMR rates being high and correlating with a higher DSA strength. There was an analysis of the PHTS registry that found that among almost 4,600 pediatric heart transplants performed between 2010 to 2021, 9.5% were performed across a positive cross-match. And there was no significant difference noted in 10-year survival between the positive versus the negative cross-match group. But this group noticed that once the CPRA was greater than 50% in the positive cross-match group, this emerged as a significant risk factor for graft loss. There was a recent UNOS analysis that was just presented at AHA a few months ago, and this analysis found that both one-year mortality and graft loss were higher in highly sensitized, and they defined this as CPRA greater than 80% compared to the non-sensitized patients. And positive cross-match was also associated with increased risk of mortality and graft loss. So some of the questions that we usually consider are who should undergo desensitization? What are the best methods for detecting antibody and how frequently should these be monitored? What is the best therapy or management strategy for desensitization? And what are the goals of desensitization? The implications of anti-HLA antibody on transplant vary based on the antibody strength. So while many methods exist, the Luminix-based assays, especially the ones with single antigen beads, are the preferred method. Access to the donor pool is determined by entering these unacceptable antigens based on center-specific MFI criteria into the online UNOS calculator so that we can determine the CPRA. But what defines an unacceptable antigen is not really universal because different centers use different cutoff values. So some use a neat MFI greater than 4 to 5,000, whereas others look at the MFI on dilution, like for example, on 1 to 16 dilution, MFI greater than 1,000, whereas other centers use MFI greater than 3 to 4,000 on 1 to 16 dilution. Usually, high-strength antibodies are generally C1q positive, so C1q testing is usually skipped. So how frequently do these antibodies need to be monitored? This is also usually center-specific, and this is an example of a decision tree from the Cedars-Sinai group. They determine whether patients have significant antibody, and if they don't, they recheck every 6 months if they're an outpatient, every 2 weeks if they're inpatient, and every 2 weeks after a potential sensitizing event. So then comes the question, when do we desensitize patients? So generally patients with CPRA less than 20% can proceed to transplant without any desensitization, whereas those with CPRA greater than or equal to 50% have increased waitlist times, waitlist mortality, and also increased risk of removal from the waitlist. So they're considered for desensitization. For highly sensitized candidates, we have a variety of desensitization strategies, and the goals for desensitization can either be to obtain a negative cross-match or to reduce the antibody strength enough to minimize the risk of circulating antibodies that fix complement. So this is a nice paper that was recently published. They looked at the PHTS database, queried it from 2010 to 2021 for all patients less than 18 years old with a known cross-match. And among the transplanted patients, desensitization was undertaken in only 4% of the cohort, 24.1% of the positive cross-match cohort, and 2% of the negative cross-match. And these patients received a variety of therapies, but the most common or rituximab, IVIG, plasmapheresis, Bortez, and then some patients received intraoperative plasma exchange and other therapies post-transplant. Desensitization therapies have been mainly adapted from the renal transplant experience, and they focus on multiple targets of the humoral immune pathway. Therapies can target antibodies by inactivation, like with IVIG, removal, like with plasmapheresis, and decreased production, like with rituximab and bortezomib. Some, like tocilizumab and daratumumab, are still, I would say, more experimental, especially in our population. Centers use a variety of protocols, and this is just an example of the Cedars-Sinai approach. There's various combinations that can be used with different dosing frequencies in the inpatient versus the outpatient setting, depending on the individual patient. And there's no large-scale studies to guide our choice. So then how do we decide which strategy or which drug to choose, whether you do it as an inpatient versus an outpatient, and how do we determine what the duration of therapy should be? The degree of sensitization and the urgency of the transplant listing usually impact the strategy that we employ. So this is, again, still an example of that Cedars-Sinai approach for adult patients. They determine patients with CPRA greater than 50%, and if they're an outpatient and they're considered to be in the less highly sensitized range, which they define as CPRA of 50 to 70%, they find it reasonable to start them with a 30-day cycle of IVIG and rituximab, then progress to a 2-week cycle of plasmapheresis and bortezomib, and then a 6-month cycle of tocilizumab. On the other hand, for this highly sensitized population that's still outpatient with CPRA greater than 70%, they may immediately start with tocilizumab because they're assuming that this strategy will be less successful. Whereas if the patient is already an inpatient, they may start with plasmapheresis and bortezomib, especially if the patient has predominantly class 1 antibodies. And if they don't have a response, then they move on to tocilizumab. It's very important for us to understand the cellular sources of these antibodies that we're so concerned about. We traditionally tend to think about the long-lived plasma cells that live in protected bone marrow niches and microenvironments, and they can secrete antibodies potentially for decades. But there's emerging understanding that's regarding the memory B cells that are constantly differentiating into short-lived plasmablasts that are also contributing to the circulating HLA repertoire. So to date, excuse me, The most commonly used B-cell therapy in heart transplant is rituximab. This is a chimeric murine human monoclonal antibody directed against CD20, which is usually expressed on mature B cells, which is this box right here. There's near complete depletion of peripheral blood B cells through a combination of antibody-dependent cellular cytotoxicity, complement-dependent cytotoxicity, and apoptosis. Studies in both pediatric and adult heart transplant patients have noticed cautiously optimistic results, especially when rituximab is combined with IVIG and plasmapheresis. But the non-randomized clinical experience has usually been heterogeneous, and particularly in the renal randomized controlled trials, it's actually been inadequate. And this is because rituximab does not prevent de novo DSA. And also, CD20 antigen is absent on the B cell precursors, which means that B cell repopulation will follow the depletion, which we typically see within 12 months post-infusion. And CD20 antigen is also absent in this group, which is the antibody-secreting plasmablast plasma cells. And because bone marrow plasma cells can survive for decades in protective bone marrow microenvironments, just removing the precursor B cells will not address HLA-secreting plasma cells, which are persisting in these reservoirs. Rituximab also incompletely eliminates CD27 positive memory B cells. In terms of the plasma cell targeting strategies, there's a few different therapeutic subclasses, two of which are proteasome inhibitors like carfilzomib and bortezomib, and also the anti-CD38 monoclonal antibodies like daratumumab. There's also bispecific antibodies, which are the new kids on the block, but I won't be talking about those. In terms of proteasome inhibitors, at St. Louis Children's, we prefer carfilzomib, and some of the reasons for that are compared to Bortez, it has better in vitro cytotoxicity. And looking at the multiple myeloma literature, it's been shown to have clinical superiority to bortezomib. And also with carfilzomib, remember that the effect is dose dependent, whereas with bortezomib, it's usually used at a standard dose. Moderate dose carfilzomib, as you can see, has a remarkable effect of decreasing bone marrow plasma cells by about almost 70%. There are some adverse effects, including cardiotoxicity in patients who are hemodynamically unstable. We have seen it cause AKI, but that's usually been reversible. We've also seen hypertension has also been cited, but we haven't seen that in our patients. And there can be hepatotoxicity, and there's less neuropathy compared to bortezomib. The Pittsburgh group with Adriana Ziwi looked at carfilzomib alone desensitization strategy, and the key points to take away from this study were looking at a neat CPRA, class 1 came down, but class 2 were noted to be minimally impacted. But the strength of this particular study is that they did serial dilutions and also looked at C1q CPRA and found that it more accurately reflected change in higher titer antibodies. And anecdotally, the class 2s tend to have the higher titers. In this cohort, 5 out of 6 patients that were transplanted were on an LVAD, and all of them survived. But the other important thing to look at is who was actually delisted and who died. And this was indeed the patients who had a homograft prior transplants or were on mechanical support. So while carfilzomib alone may be a great strategy, it's probably not enough. And one of the reasons for that is that plasma cells can become resistant, and there's a couple of different possibilities here. So the first is that the plasma cell subsets may have different susceptibility altogether to the proteasome inhibitor. And in vitro studies have also interestingly shown that proteasomes can undergo adaptations to then become resistant to the inhibitors. So we need therapies that target plasma cells through different mechanisms. And one of these strategies is the CD38 targeted therapies with daratumumab. It has pleiotropic effects and has been used very effectively in multiple myeloma. And the nice thing is that it doesn't have any cardiac or neurotoxicities. In the non-human primate studies, daratumumab, when used with a stem cell mobilizer, significantly reduced DSA. Another interesting thing about daratumumab is that CD38 is also expressed on NK cells. So it's possible that there could be potential adjunctive benefits to prevent early AMR. There have been a few case reports, mostly adult, but as you can see here, the Dallas group also published a PEDS case that have all shown that antibodies come down pretty nicely with daratumumab. In the adult heart transplantation literature, there is an ongoing clinical trial out of Mayo, so we'll have to wait and see what the results of that are. But the caveat to daratumumab is that CD38 is widely expressed on various cell lines, especially on the regulatory cells. And these are our Tregs, Bregs, and our myeloid-derived suppressor cells. In non-human primate model, even though the antibodies came down, once they were transplanted, they all developed T-cell mediated rejection. And when they stopped the drug, the DSA rebounded. There are emerging case reports that in humans, the same thing may be true. There's a report of kidney antibody-mediated rejection where the patients developed T-cell mediated rejection and the DSA rebounded. There's also another case report of steroid-resistant T-cell mediated rejection in the early post-transplant period in a low immunological risk kidney transplant recipient who was receiving maintenance DARA for multiple myeloma. But all in all, to say that we have a variety of challenges, and that's because there's variability in the etiology and degree of sensitization for our patients. There's a lack of standardization across HLA labs. There's also a lack of standardization of sensitization cutoffs meriting desensitization. And there's deficits in our understanding still of the factors driving memory B cell and plasma cell differentiation, persistence and resistance to desensitization. And the other question is, does desensitization alter long-term outcomes? I look forward to your questions in the chat. Thank you.
Thank you very much for this extensive overview of different strategies you can use in the pediatric heart transplant patients. I will go next. I'd like to introduce the next and the last speaker already from this afternoon, sorry, Dr. Sarah Nicholas. She is the Clinical Chief of Allergy and Immunology and Medical Director of the Texas Children's Hospital Infusion Center at Baylor College of Medicine and Texas Children's Hospital. But she's also the founder and director of the Solid Organ Transplant Immunology Program, which addresses the immune concerns around solid organ transplantation. Today, she will talk about the approach of the highly sensitized pediatric lung transplant candidates.
Hello, thank you for having me and thank you for that introduction. I have to say that the lung section of this is a sort of bit different from the data standpoint. There's very little data in lung, although there are a couple of nice papers. They mostly really look at peri-transplant sensitization and less so at sort of like the lead up to transplant, sort of pre-transplant desensitization. So we'll go through those at some length. So to start off with, I think we all sort of understand that the root cause is that we have sensitized patients and that they sit on the list for longer. There is sort of this nice study showing 746 adults listed for transplant. And the group that was sensitized had a significantly decreased likelihood of being transplant and a significantly increased risk of dying on the list, none of which would surprise any of us, I'm sure. There is unfortunately no pediatric data on this. And in fact, I had trouble finding even any data on the extent of sensitization in the pediatric population. I suspect this tracks with the fact that anecdotally, our lung transplant patients at least in pediatrics, tend to be less highly sensitized than overall the heart transplant population is. It's probably largely due to their underlying diseases, and these are patients that have had fewer runs on bypass, fewer transfusions, generally fewer graft material that's already been put in. So they look sort of more like a little bit different than the heart transplant population. So on the adult side, again, this is one of several sort of descriptions of peri-transplant desensitization protocols or perioperative protocols. This was a non-randomized single center experience, and basically they took all comers who had an appropriate graft from other standpoints. And if they had no preformed DSAs, they, just went ahead and did their transplant as is. If they had a preformed DSA, they did 1 round of pheresis immediately before they went to the OR, and then ran a sort of emergently run cross-match DSA again. They then split their group into what they called a high preformed DSA, or a no preformed DSA, or a low preformed DSA, based on that post pheresis titer. And the only thing is that they defined their high group as was still less than 5,000 MFI. They actually excluded anybody that had more than 5,000. And if you fell into the high category, you then went on to receive a desensitization program with plasma exchange ×5, rituximab, and IVIG. They found between all 3 groups, basically, that there was, similar freedom from CLAD at 3 years post-lung transplant was similar between the high, the low, and the no preformed donor-specific antibody groups. They also found that it was freedom from CLAD was lower in patients who did not clear their DSAs after the desensitization protocol. So even though overall, they found that this was a successful program and everybody had similar outcomes, if you drilled down on the group that had persistent DSAs post the desensitization program, those are the patients that suffered the most. And I think that helps us understand why we need further, more aggressive strategies in a fair number of our patients, and some of the things that we're all interested in looking at sort of moving forward. They overall found no difference in ACR diagnosis between the groups, no difference in AMR diagnosis between the high, low, and no preformed DSA groups. And then they did have this group that I mentioned that had the persistent DSAs despite the desensitization. And these patients were at higher risk for AMR than the rest of the population. That was sort of the other biggest thing that they found. In terms of graft survival, they had a similar no difference between the groups, and the graft survival was again lower in the group that did not clear their persistent DSA. Again, this is more of a no desensitization protocol, and looks at, I think, really how relevant some of these antibodies are, and gets at the question of whether they need to be desensitized or not. So this looked at a group, again, a retrospective cohort of adult patients, so no pediatric data again. They found patients with a low level preformed DSA in 8% of their population, and they define their low, in this case, as an MFI of 1,000 to 6,000. And they found with no additional intervention that there was no difference in retransplant free survival and no difference in CLAD free survival. This was the only study that was specific to lung that really had a true pre-transplant desensitization. These patients had, again, it was a retrospective cohort of 18 lung transplant candidates. They had a median class 1 of 73 and class 2 of 89%. So these were fairly highly sensitized patients. 8 of them completed the protocol, but they included data on more than that because many of them completed a significant portion of their protocol. And this was a plasmapheresis, methylpred, bortezomib, and rituximab protocol. And in this, the reasons for not completing were either they went to transplant with a negative cross-match or they had to delay therapy due to thrombocytopenia. And out of this cohort, 9 of them got transplanted. And unfortunately, what they found was that in terms of the class 1 antibodies, there was no significant change in the antibody titers, but there was a minimal change in patients that had partial desensitization. And then in class 2, they found no change, which tracks with sort of what's been seen in other studies, that bortezomib and rituximab really are not enough to impact our class 2 DSAs, and that you really need other agents. Again, I like this paper because there is a follow-up paper, and this is one of the only studies with a significant amount of long-term follow-up. Patients, again, received sort of perioperative desensitization. This was a retrospective cohort of 340 patients. 53 were in this DSA positive group. 93 were in a highly sensitized but DSA negative group, so PRA positive, DSA negative. And then 194 were sort of non-sensitized patients. These patients were transplanted basically they tried to transplant them if they were with a negative cross-match, unless they had a PRA greater than 30% or they were medically urgent. And if one of those two criteria were met, then they desensitized them with Plaques, IVIG, ATG, and MMF. And then you can see the immunosuppression for the other groups there. Between the groups, there was no significant difference in a lot of the primary outcomes. So grade 3 PGD, 30-day graft survival, 1-year graft survival, CMV infection and fungal infections, importantly, were also not different in this group. ACR of grade 2 or higher was actually less common in the DSA group and in the PRA group. I've seen data that looks like this before in some of the ABO incompatible literature, and I wonder if this just has to do with the augmented immunosuppression, but it's an interesting finding. This is the same group of patients, and they did a follow-up study to report out longer-term outcomes in these patients. The DSA positive group, the DSA positive, DSA negative, PRA positive, and then unsensitized. And they found in a sort of much longer-term follow-up very similar things. There was just really no difference in allograft survival, clade-free survival, when you look at the 3 different groups, and then when you break it down by the amount of DSA or the MFIs that they had, and they sort of broke it down by less than 10,000 or more than 10,000 MFIs in this group, they still did not find any significant difference between the groups in either allograft survival or clade-free survival. Again, this is sort of a looking at flow cross matches and doing a peri-transplant desensitization protocol based around that. We sort of continually are coming up against the same type of data, that there is not a huge difference if you do some sort of low-level peri-transplant desensitization in patients with low MFI positive cross matches. Here, these were flow cross matches where either the virtual is negative, in which case they didn't do anything, the virtual is negative, and the flow is, the virtual is positive, flow negative, or flow negative and virtual, flow positive, virtual positive. And in that case, they were doing TPE, IVIG, and ATG. And they really had a similar outcomes in terms of graft survival by sensitization cohort. And they had also similar de novo DSA free survival as well in this cohort. I think I left out maybe 3 studies that came up in the entire PubMed search of lung transplant desensitization. So this is actually a pretty comprehensive overview of what's out there. And I think that highlights sort of the extent of the limitations. So there was no pediatric data. There was, in fact, one case study that looked at desensitization for a 14-year-old who needed an ABO transplant. But there was really no other data in the pediatric literature at all. Obviously, these groups are very, very variable, and the study designs are pretty variable. The protocols, to some extent, change a lot how they did the protocols, but then also none of these include some of the more the drugs that are emerging in the kidney and the heart literature as things that we might want to use, and things that we would really need to use to target class 2 antibodies. And there was no sort of randomized trials. There's no prospective data. The lack of obviously HLA lab standardization and cutoffs makes this complicated, and then limited long-term follow-up. And then I think the other thing that comes out a lot is the drug toxicities in these studies. I did, just sort of in terms of future directions, wanted to spend like a minute or two on this drug that I find really interesting. Imlifidase is a derived from strep pyogenes. It is a endopeptidase that cleaves the IgG molecule in the hinge region. So you end up with just these two free-floating particles that have no function and get filtered out. You get a transient decrease in IgG levels, but you do then get rebound. And it is approved on some level in the EU for use in kidney desensitization. It is under review in the United States, and it does have orphan drug status. So it is, sort of moving through the process. There are a few risks, so this is not like a magic medication. I think the rate of infusion reactions is fairly high. Obviously, there's risk of infection. People can get elevated transaminases. There's a fairly high rate of anaphylaxis along with the infusion reactions, and serum sickness, particularly with subsequent doses. And I think with subsequent doses, you can also sort of start developing these anti-imlifidase antibodies that can neutralize the drug itself and make it less useful. There is one report of imlifidase desensitization that I just thought was worth kind of mentioning. It's really hard to see, but these lightning bolts here are when they gave the imlifidase. So this is a patient who overall they had tried, sort of a variety of things, including plasmapheresis and rituximab, and really not made much headway. They gave the imlifidase. This is sort of day before transplant when they gave it, right before they gave it. This is sort of right after they gave it. And you can see there's this really dramatic drop, which you can see in more detail down here. There was a very dramatic drop in the level of PRAs, and both class 1 and class 2 were significantly decreased, as one would expect with the mechanism of action of the drug, but it did rebound fairly quickly. This is day -6 here, and then by the time you get out to, day -1 here, you have a pretty significant rebound of your antibody levels. But I do think it's an interesting drug on the horizon that we should all sort of be aware that's out there. So just my sort of last thoughts are that there's a lot of mechanisms of how we eliminate antibodies from the body. Obviously, the previous speakers did a really nice job touching on some of these, so I won't go into detail. I think the only other one that hasn't been mentioned maybe is isatuximab, which is just a different brand of CD38 monoclonal antibody that may have some slightly better tolerability profile. I have not yet used it just because of ease of availability in my institution, but it's sort of an interesting option. If I was practicing in Europe, I would have much better impression of antibody removal. I think that immune absorption data is much better than plasmapheresis. And so, in North America where it's not available, I think, we have really limited outcomes with plasmapheresis. I guess we haven't really talked much about C1 inhibitors, but that's sort of another interesting sort of pathway interrupter that could be used peri-transplant, as is eculizumab. So I look forward to answering any questions.
I just want to thank all the speakers. Really appreciate your time and all the information you shared today. So we're going to start with our panel discussion. Please place any additional questions you have in the chat so that we can include those as time allows. So the first question I wanted to ask our three speakers, I'll start with Amanda, particularly for this case that you presented, is that now that you've had some time from this case, I wonder, as a team, have you adjusted your initial protocol and the approach to the highly sensitized patient, or what would you have possibly done differently?
Thank you for the question. You know, if I think back correctly, I think the case I presented was the first patient we used daratumumab in at our center. And it has now been well integrated into our protocols. And that's low-hanging fruit to say that it wasn't something we even considered before, and now we use it regularly. But I think also we are not fortunate to have someone like Dr. Nicholas at our center who can weigh in on therapy regimens quite as intensely with that expertise. And I think being very intentional about what we're targeting and kind of antibody profile the patient has been really integral into making our AMR and our DSA treatments more appropriate.
A follow-up question to that is, you mentioned now that daratumumab has become something that's been integrated pretty heavily, and what is your use in this approach to the highly sensitized patient now?
So we seem to have a lot of patients post-transplant who show up with high levels of class 2s, as opposed to more diffuse DSAs. And in those patients, we've had success with treating their AMR with daratumumab. And again, that's just not something we were able to do prior to this patient that I mentioned.
And what about in the sensitized patient pre-transplant? I'm curious.
You know, I was trying to think back. I don't know that we've had another patient that's quite the same as this case, or that we've had the opportunity to use DARA in since that time. We've just been fortunate that most of our patients have not needed it.
And are you using it now first line for your AMR, or are you using it in combination with like other drugs such as IVIG, rituximab, bortezomib?
I think all patients are, considered individually, but pretty much everyone will get some amount of IVIG and plasmapheresis. And then we'll consider the agents depending on their antibody profile from there. But I would say I would have to look back to see all the patients that we've treated in the past few years, but many of them have gotten DARA as part of their arsenal.
And then my next question is for Dr. Gokunpudi at WashU. So you say that you've changed over the years as far as your approach, less rituximab, even maybe perhaps less bortezomib. What is your approach now to the highly sensitized patient pre-transplant who you're trying to get in the best state possible to be able to have a transplant?
Yeah, so it depends on how highly sensitized they are. If they have PRA that's pretty prohibitive, we actually are starting to use the carfilzomib along with co-stimulatory blockade, and we've had good success with that in terms of our antibodies. And for patients who, for example, don't have class 2s being their significant antibodies versus those who are not as significantly sensitized, so maybe CPRA is less than 70%, then we do try the other therapies, and we have tried we've tried daratumumab, carfilzomab alone, and all of that. But we have noticed that we get the most bang for our buck when we add on co-stimulation blockade.
Thank you so much for that, Lakshmi. And then I'm wondering, Dr. Nicholas, what your approach recommendation these days are for the highly sensitized. And I know you work across solid organ, so you don't have to just comment on lung, but what your approach is.
Yeah, I liked sort of Amanda's comment that we sort of take them as individuals and think about their HLA profiles, because sometimes that's really important. I think in the patients who have class 1 antibodies predominantly, we will sort of do a more traditional rituximab with bortezomib, usually attempt at desensitization. We don't tend to do a ton of, I should preface this all with, we don't do a ton of desensitization here. But that is our general strategy for AMR or for desensitization, is that we would do Ritux and Bortez if it's a class 1. If it's a class 2, I really think you have to use something like daratumumab, because otherwise we just tend not to make much progress at all. I don't tend to do any of the plasma cell inhibitors without rituximab, because I think it's sort of like closing a door, but having like a big hole in it that lets stuff come through, right? Because if you don't kill off the cells that are sort of precursors to the plasmablasts, you've got no reason for them not to just come right through and continue to make more. And given the relative toxicities of the drugs, and then also the fact that we're using these drugs so far off label, that I feel more comfortable generally doing rituximab plus in that scenario than sort of a plasma cell either inhibitor or CD38 monoclonal by itself. We tend to not do very much pheresis or IVIG for desensitization because we just haven't found that it's effective, and it adds expense and risk, especially for pheresis with the line, and in kids it's sometimes annoying and complicated for them to have that. So we tend to leave that, and I think the issue of rebound is pretty significant.
Thank you. Next question from the chat is that in cases of patients who are sensitized and undergoing an anticipated positive cross matches, what would you augment at the time of your transplant?
Is that for me?
You're welcome to go first.
Okay. We do, so for heart, we do not do ATG as standard induction. We just do steroids. So in those cases, we would do ATG for our induction therapy. And then oftentimes add daratumumab off the bat, although we don't do very many positive cross-match transplants. We really try to avoid them, or at least find one that's a very low level. And then we sort of have a take it as we go approach in terms of how long we continue the daratumumab, what other agents we employ. We also would do rituximab in that scenario, and we either do intraoperative exchange or TPE in that scenario. For the lung transplant patients, we have done one positive cross-match lung transplant in the past year or so. And that patient did get daratumumab, and ATG was already part of our planned induction for her.
Thank you, Dr. Nicholas. Same question for you, Dr. Govinpudi.
Yeah, we do TPE intraoperatively and post-transplant for about 5 days, and also thymoglobulin. And then depending on how strong the cross-match is and how concerned we are about complement fixation, we add eculizumab into our induction protocol and also continue it post-transplant for maintenance. And there have been some patients who after a positive cross-match transplant have developed early AMR, and in those patients we've used daratumumab, tocilizumab, just kind of thrown a lot of different things at them depending on which antibodies are problematic.
Thank you. The next question from the chat is an interesting one that I have not personally thought of, is that there's some mention in from one of the members in the audience of noticing that the ABO titers will reduce as well during this time that you're desensitizing. So has anyone seen a significant decrease that's actually allowed for them to have an ABO incompatible, or at least consider ABO incompatible? And I'll go with you, Dr. Govinpudi, first.
So we haven't found anyone who can undergo ABO incompatible transplant, but we have been having a lot of conversations about following that, especially as we have been adjusting our desensitization protocols recently. So we plan to look at that in the future.
Thank you. Amanda or Sarah, any comments on that?
I mean, it stands to reason that it would happen. I don't think we've had a scenario where we've had that exact situation, but in general, you should decrease your antibody production, although it's IgM, not IgG. So sometimes different things happen, but in general, you should decrease antibody production to ABO.
And then Dr. West did not put her question in the chat, but I'm going to defer to her. What question do you have, Dr. West?
Thank you very much. Well, actually, that was my question about the ABO in the chat, but I just wanted to mention that you know, it is another approach to thinking about these really, really difficult patients with 100% PRAs. And I know Anne-Marie's on the call as well, who wrote up one of our recent cases where we actually successfully transplanted an older child with that sort of thinking, because it's such a difficult problem. And the ABO antibodies are actually both IgG and IgM, despite what's sort of in the old literature, and also IgA actually. And it really gives an opportunity to think about a different way to approach these patients who otherwise are, you know, many of them will never get transplanted because of this issue. So it's something to think about, at least measuring the ABO antibodies. And, you know, we're doing trying to capture a lot of this information from colleagues worldwide. And if you have any if you'd like to work with us on some of these, we'd be happy to coordinate. We've developed a new Luminex test for ABO antibodies that's very similar to the Luminex test for HLA. And so there's an opportunity to really bring some standardization into the field of ABO antibody measurement. Sorry about that sound. That's the snow falling off of the frozen roof. Anyway, lovely session today. Thank you.
Thank you, Dr. West, and I apologize for losing track of you in the chat. There's a couple questions that are related. So some of the questions are, what are the long-term implications of using these aggressive desensitization, you know, in these patients, and what are their long-term outcomes, including the risk of graft vasculopathy? Are we improving that, but also the risk of PTLD? And I'd like to hear your thoughts, Lakshmi and Sarah, on that. Whoever wants to go first.
I can go. I would say that we still have to follow a lot of our patients out, given that a lot of the new therapies are fairly recently implemented. But I would say that there is an association in the literature with PTLD and using desensitization therapies, especially if you look at eculizumab, and if you look at co-stimulatory blockade like with belatacept or abatacept, those have, you know, the insert talks about PTLD, especially if the patients are EBV positive. But I think PTLD is sort of a nebulous disease where there's so many different etiologies. And so it's, I think, hard to pinpoint what is particularly causing the increased PTLD.
I'm trying to think if I even have anything to elaborate on. I think that was, you know, I agree that it's really hard to track, and we are looking at this data, but I don't think we have an answer for it in our patients, I would say in general, who have been treated with augmented immunosuppression for whatever reason. We have more data in patients who have been treated for AMR than who have gone through desensitization protocols or positive cross-match protocols. But I think in general, I mean, the expectation would be that it might be higher, but I don't know that that's actually borne out.
Okay, we have time for a couple more questions. One of the questions that's come up a couple times in the chat is, does the timing of these drugs and the order at which you give them in desensitization matter? And if you would like to elaborate on that.
I think, so I have like a couple of rules that are like not hard and fast, but what I think about, and others, I mean, I think there's a lot open to interpretation and opinion. I try not to give more than one monoclonal in a day, although sometimes we do. If we're going to do pheresis, we give, you know, an antibody-based drug, and you know, after the pheresis, not before. You know, rituximab, we usually give, at least at our institution, we can't usually get 7 consecutive days of pheresis, so we try to give drugs like rituximab, you know, on the day that there's a break, so there's more time for it to marinate with the B cells, things like that. If I am doing pheresis, I feel very strongly about giving rituximab, because there is some data that it can cause like rebound, stimulating your B cells to make more antibody. Otherwise, it's kind of more of a practical, when are we going to give this drug versus another drug? I don't know if anybody has any other, be curious.
No, I agree with that. And the only other thing I would add is we also give the drug, some drugs tend to have a lot of hemodynamic instability associated with them. So we make sure that the space between those two is, at least 6 hours or so, depending on which drugs we're using.
Dr. Nicholas, really quick question. Thanks for that explanation. So when you're talking about rituximab in the midst of a pheresis run, and we also don't do it consecutive days, would you say like over the weekend, or, because sometimes when we wait for seven pheresis runs, it's like after 2 weeks and you feel like you're sort of just whittling, or just
Yeah, so there is actually some data to show that rituximab within like 24 to certainly 48 hours has bound to all the receptors that it's going to bind, and that actually most of the B cells have been, eliminated by then. So usually what I try to do is like, if I know like I have pheresis Friday and then I don't have a pheresis again until Sunday, if you give it Friday afternoon, then that's, I think, enough time for it to marinate. And I haven't had any problems with depleting my B cells, so I think that works just fine. Even if you just have one day off to sort of have that period of time where you can let it sit for a little bit longer.
And would the same for DARA, probably?
So DARA, you're going to dose weekly usually anyways, so I'm less worried about it being pheresed off. I think we have done a variety of things with the daratumumab. A lot of times we just wait until we're done with pheresis. I don't know if any of you, I'd be curious to hear, have done sub-Q daratumumab, but we at this point are only doing IV, and it is so reactogenic that we've had such a high rate of kids having bronchospasm, kids having various other like anaphylactic type reactions, that I have been hesitant to do it in the midst of a whole lot of other things, just because, not precipitating chaos. So we often leave it till the end when we're done with pheresis.
We have only a couple minutes. If Lakshmi and Amanda, you want to get a quick comment on that, and then we're going to have to wrap up.
I don't think I have anything to add for that.
I don't either, other than to say we have also had some, I hadn't used the word reactogenic before, but that's exactly right, responses to DARA. So, and we can never tell, obviously who's going to have that issue.
Well, I just want to thank all our speakers. I'm sorry we didn't get to every question in the chat, but I know a lot of them were answered by the speakers as we went. And just, it was really good conversation. Thank you to all our participants. And you can let anyone know who was unable to attend that this live recording will be available later for viewing at a different time. But thank you to everyone for participating. And that concludes our webinar.